study of health communication, and my apologies for to those of you who already are familiar with this. We'll try to kind of bring everyone to the to a similar page. So interest, thank you, emerged in the late 1960s. There had been some work that we would consider health campaign research, going back primarily to health sociologists in the 1940s. As they were looking at various media effects. Some of the things that they looked at were health campaign issues, so there was a little bit to build on there, but very little. Most of the work that had been done at this time focused more on the interpersonal context, the provider-patient interactional context, although we would frequently use the term doctor-patient interaction rather than broadening it to healthcare providers more. There was, of course, this realization that in many situations, communication is the means of treatment. It's not just the means of a diagnosis. It's not just communication that is used to try to persuade people to adhere to treatment regimens, etc. But that communication is in and of itself therapeutic, and that dimension to health communication has continued to be an important one. Great. Thank you. Thank you. So, some key areas of health communication that are these interpersonal concerns, social, cultural concerns. I know you're getting well educated here in this area. You've got the master of the critical cultural approach to health communication here. Organizational and small group issues, although never as many as would have been helpful to have. We've all been in hospitals, at various healthcare organizations. We know all of those healthcare issues that are relevant there, and they haven't been adequately studied to this point. This has always been an area in the journal, for instance, in which I would have liked to see more submissions. Mass-mediated and persuasion dimensions have always been important as well. So the work at its best is multidisciplinary, interdisciplinary, and transdisciplinary. So multidisciplinary involving multiple disciplines, as we see represented. I'm so excited about this in this room. Interdisciplinary, bringing together perspectives, and then transdisciplinary, going across perspectives. And the best work involves these combinations of perspectives. One of the features that we've started, you get old, it takes your brain a while, so there will be times when I will have long pauses trying to think of the word. One of the features that we've started in the journal just recently, as a matter of fact, it may not have come out yet, but it's a feature that Roxanne Parrott started called Keeping the Health in Health Communication. Communication experts have expertise about health. Medical and public health experts have that expertise about health that we need to bring together to work most functionally. So we've got a few pieces in press for that. I don't think any of them have come out yet. Have you been paying attention? Yeah, I haven't seen them either. And I do proof every issue, so you'd think, I know I have proofed some, but I don't think they come out in hard copy. They come out online through iFirst. That's what it is. So Roxy Parrott is one of the scholars who has been a big advocate of the multidisciplinary, interdisciplinary, and transdisciplinary approach. She thinks that no communication scholar should do work on their own without working with someone in public health or medicine or social work, etc. And the quality of her work reflects that. So we see working together social scientists, various medical humanities scholars, physicians, nurses, allied health providers, although I would like to see a lot more allied health providers involved in our work. We do get some submissions from pharmacists. Pharmacists have over the last couple of decades been required by law in the U.S. to communicate more with patients. And that's generally a pretty productive process. So that's been studied some, but not nearly as much. Some patients are surprised to find out that their pharmacist knows more about pharmaceuticals than does their doctor. Now, I'm not quite sure why they're surprised at that. That's what the pharmacist is expert in. But I guess perhaps a lot of us don't think about it in that detail. Certainly those people in this room would not be surprised by that. I've had a submission or two from physical therapists or occupational therapists, some from dentists, and I've tried to encourage that over the years. That's such an interesting area. The problem is that while public health scholars receive strong training in methods and in theory and know how to do good research, people in dental schools don't. They have a simplistic conceptualization for the most part about the research process and certainly about the process of communication. They say things like, we should communicate more. Like, communicating more is going to solve our problems. So that's where working together would really be useful. Perhaps something some of us can do in the future. Of course, campaign designers and implementers, health PR practitioners, public health scholars, etc. Those are the primary groups of people we see trying to contribute. Now, every now and then, and maybe it's more than every now and then, it seems to be happening a bit more frequently, I will receive a submission from someone who has obviously never opened a copy of the journal before. So in general, for all of us, that's an important reminder. Read the journal before you submit to it. I try to be polite in my desk rejects of these pieces, and I try not to say, have you ever read the journal? I put it a little bit more polite. I think, tell me if you think this is more polite. Perhaps you have never had a chance to read our journal. What do you think? Is that more polite? I think I'm doing pretty well on that. Polite. Because I'll use my son will be sitting next to me. He just graduated from college. So he's hogging the couch while he's allegedly job hunting. But I'm not seeing as many job applications go out as I would like to. And I will say to him, I say, listen to this, like he cares, but I'll read him this, the title of a piece, and he'll say, what does that have to do with communication, let alone health communication? Even he, a non-health communication person, although he's been listening to me, complain for a lot of years, can tell that these are not communication studies. They do tend to be focused on health issues, and that's good, but they should be read in a venue where the practitioners of that health field will be familiar with them, not one where the readers expect theoretically sophisticated, methodologically sophisticated, and conceptually sophisticated research. So some of the people then, all right, what did I just do? Okay, good. I turned it off, but I turned it back on again. For me, that's doing pretty well. I'm not very sophisticated with technology, which is strange. I started using computers before most of you were born. 1973. Right? Am I right? A lot of you were not born. Yeah. At that time, those were big mainframes, computers, where we carried our box of IBM cards to the input-output window, etc. So, and so you would think maybe I would have kept up a bit, but no. I'm lucky to do the bare minimum that I need. All right, so some of the key foci then in the journal, and we'll talk a bit about some of the other journals as well, although the journal Health Communication was the first to begin to publish work in this area. So, provider-patient interaction, initially it seemed that people thought that was all we were interested in publishing. I remember people saying that at conferences and things. That was never our intention. That was just the kind of submissions that we originally got. Then, fortunately, we moved on to some submissions, really fabulous ones in health campaigns and risk communication. Various issues of health information in the media and advertising, including computer-mediated communication and social media. I get so many submissions now on issues related to computer-mediated communication and health information in the social media that I have a terrible time finding enough reviewers for them. As a new area comes up, a couple of people will start doing work in that field, and you end up sending them everything to review. You can't keep burdening them in that way. One of the things that I find particularly fun is the notion of everyday health communication. There's apart from the information that we get from doctors and the media and health campaigns, etc., there's so much everyday health communication. And Becky Klein was the first scholar in communication who really wrote about it in this way. I've been nagging her for years to write a book on this, and she keeps saying, someday, day. And she's a little older than me, so I'm not sure that someday will ever happen. A lot of work over the years on social support, stress, and coping. We know the impact of social support on health. We know the role that communication plays in that social support process. And then more and more recently on health literacy. So that's very exciting. So, some key publication outlets and sources. Most of you are probably familiar with these. Health Communication, that's the journal that I edit, and I think I've been doing that for 28 years now, because I was pregnant with Elise when I first started accepting submissions for it, and she turns 28 in December, so that's how I keep things straight. Who was I pregnant with? I've only had 2 babies, so that doesn't really help that much. But qualitative health research, fabulous journal, really high quality work. The Journal of Health Communication that Johnny come lately that that I was very unhappy about when Scott Ratson started publishing that. At that point, I was still being published by Lawrence Earl Baum, and Journal of Health Communication was being published by Taylor and Francis, who is now my publisher once Taylor and Francis bought out Lawrence Earl Baum. And Scott told me when he first started Journal of Health Communication that it was going to be different than health communication in that it would primarily have more of a social marketing perspective. Well, the first time I said that in public, he objected to that. But it has had traditionally a bit more of a social marketing perspective. Initially, Journal of Health Communication did have more international scholars and reviewers than did Health Communication. We had started as primarily a U.S. journal, but boy, that didn't last along, word gets out about publication outlets. People see a journal cited, and now we probably receive more submissions from international scholars than we do from U.S. Scholars. So that's really been a wonderful turn of events to broaden the perspectives that we are able to provide. And patient education, sometimes it's called, at some eras it was called patient education, sometimes patient education and counseling. I think that's what it's called now. Started more by European scholars, but now also publishes from scholars around the world. It's the emphasis is more on provider-patient interaction in there. Communication in Medicine, newer journal, and then a couple of non-journals, but more recent publications, the Encyclopedia of Health Communication. A couple of people in this room published in there. That was an interesting one. Sage published that, and when they first contacted me about editing it, they were thinking one volume, about 200 entries. So I started putting together a list. I contacted people like Mohan, etc., from around the world, and we got such great suggestions that Sage then said, let's make this 2 volumes, 400 entries. Okay, good. We went full speed ahead on that. Before we knew it, they were saying, let's make it 3 volumes, 600 entries. So that came out not this past summer, but the summer before. Now, I understand that there are some European scholars who are working on a new Encyclopedia of Health Communication. I only found out about this because I got an invitation to write for it, and I said, what? We just had an Encyclopedia of Health Communication come out. Why would you think we would need a new one? Were there problems with the old one? Never got a reply. Never heard back from them again. So I'm assuming that that's still going forward. Have you heard anything? No. Well, if you haven't been asked to write in, it can't be going forward. And then we've had 2 editions of the Handbook of Health Communication as well. So these are those both of those big tomes with rather thorough review articles. So these have been some of our key publication outlets. So Health Communication, as I said, first came out in 1989. We now publish 12 times a year. Our acceptance rate has been stable for, I swear, 2 decades now, at about 13%. High impact ratings and international in scope. There were a couple of South American scholars about 2 or 3 years ago who looked at that time, all 272 communication journals in the world. Did you even know? I had no idea. I had no idea when they contacted me. So they looked at Scopus data, Web of Science ratings, Google Scholar metrics, and they created an overall index because each of those provides some valuable data and are limited in some other way. So they created an overall index. Health Communication, out of those 272, was rated number 13. There, higher than any other mainstream communication journal, except for a Journal of Journal of Health Communication was just below us, which of course made me happy. I never told Scott that, but you all know that. So a little bit more on historical evolution of what's been published. As I already mentioned, the earliest submissions all focused on provider-patient interaction. Over the years, there was more and more on campaigns, health campaigns, until we got to the point where a lot more of what we publish focuses on health campaigns than it does on provider-patient interaction. Fortunately, over the years, more emphasis on theory. The early work was rather atheoretical, not based in any particular, bless you, a theoretical framework, and we know that limits our research. Not only does it limit the value of that particular study, but it limits the generalizability of the findings related to that topic. So if I do a study and apply the extended parallel process model and my findings support the model, then that further increases what we can do with that model and the value of that. So fortunately, over the years, we've seen more emphasis on theory, increasing interest in analyzing health information in the media. In the early years, we only got a few submissions on that. Now we get tons because there is so much more available there. We've always known the power, the value, the impact of health information in the media, but now there are so many more media available, and it's much more difficult to stay away from it. I'm not a person who spends any time watching television although with my son having graduated back home and on the couch next to me, sports. Constant sports on the television. That's not helping me much, but I figured this might be the last time he'll ever be living with me, right? Maybe someday I'll get a job and then won't be living with me, so I want to take advantage of that. So a lot more health information in the media, a lot more mediums available, and what I have found particularly interesting is more and more scholars from various other areas turning their interest to this area. So persuasion scholars realizing the applicability of persuasion theory and research to the health care context and bringing their expertise there. Media scholars, those who emphasize media effects research, bringing their expertise. So we have seen more and more scholars from various areas turning their interest to this topic. So some notable trends. The foci of provider-patient work has become much more dyadic. Some of the early work looked just at the healthcare provider, or occasionally, not as frequently, just at the patient. Well, that doesn't give us a very good idea of what's really going on in communication, because communication is always dyadic, right? We learned that in our basic communication classes, but it's much harder, of course, to study provider-patient interaction from this dyadic perspective. Fortunately, people are doing so. More emphasis on conversation analysis. Work by scholars like John Heritage, Wayne Beach, Jeff Robinson have made fabulous contributions on a very microscopic level, discovering that different amounts of information are elicited from patients. If the doctor says, do you have any more questions, or do you have some more questions? Now, what a subtle wording difference, right? But an important communicative difference. So I find that a very exciting trend. That kind of work, of course, is very difficult to do. There are several great European scholars who are doing work in this area as well. So that provides a lot more depth to our analysis. We also see increased emphasis on critiquing that work which is just provider-centered, trying to move us along, creating more collaborative communication between healthcare providers and patients. A lot of emphasis on shared decision making, on collaboration, etc., on environmental restructuring and how that has changed communication. When you go to the doctor now, is the doctor typing things in on a terminal, or is the doctor looking directly at you and talking? What is your experience been? Because I don't know what it's like here in Singapore. Because in the U.S., the doctors are on their terminals typing things. That environmental restructuring has changed the nature of interaction between patients and providers. Just a small a factor that the role of technology in general, of course. Scholars have been writing really since the 90s about telemedicine and those kinds of technological issues and the value of those, and research in that area has expanded. Medical socialization is another interesting one. How care providers of any type are socialized to interact with patients. Medical mistakes, a very interesting one. And then again, fortunately, more on the role of the patient. As I mentioned before, we don't get as much on organizational issues as I would like. But we have received more articles on the stress of working in healthcare organizations communicatively, how this is handled, topics such as whistleblowing. What does the nurse say if the doctor makes a mistake and the nurse notices it but no one else does, etc. Subtleties of communication amongst healthcare providers, because just like good research is done from a multidisciplinary, transdisciplinary perspective, so is good healthcare. People with various areas of expertise working together, so you see the notion of teamwork down there as well. Various confidentiality and privacy issues, and challenging the bureaucracy, always difficult. A lot more emphasis on diversity concerns, which of course many of us find very exciting. Some of these have been things we've been aware of since we've really started studying health communication. Others of them are newer ones. So, of course, status differences is not something we've always been aware of. Gender differences have been being studied since about I'd say maybe the late 80s. Sexual orientation, more work on health communication and healthcare delivery with transgender individuals. I had a reviewer recently who said there are no different health problems for transgender individuals than there are for C. That was my reaction. We laughed. Are you kidding? Well, I guess this is not the reviewer to send it to. So we do have to be aware of that. Various issues of race and ethnicity and how they impact communication, language disabilities, and other disabilities. Kind of getting back to some of my original interests. One of the things that I had always noticed with my little brother was the fact that healthcare providers paid attention only to those health problems that he had that were related to his disabilities. So he's got cerebral palsy, severe hearing loss, probably some retardation, although in some ways he's smarter than all of the rest of us. So he's got multiple disabilities, and the healthcare providers pay attention only to those things. So when he, when his gallbladder burst, he had great difficulty conveying to his healthcare providers what was going on. Almost died, and you're not supposed to die anymore from a burst gallbladder, but he has difficulty speaking, and I was not there. I'm going to have to move. They live in Kansas City. I'm going to have to move to Kansas City in a couple of years to be his personal health communicator. It's not exactly where I plan to retire. Kansas City is not a vacation paradise, but that's where my brother is, and he needs a health communicator. Even when he was a young man, and I'm not sure if this is culturally appropriate to talk about. So stop me if it's not. I should have checked with you about this ahead of time. But anyway, when he was a young man, one of his testicles didn't drop. Is that okay to talk about? All right, thank you. Good. And no one noticed it. Now, don't you think that's kind of obvious? I don't have any myself, but I think that's kind of obvious. I was the one who noticed it. I was back home visiting, and he couldn't get in and out of the bathtub and things like that himself, so we always helped him and noticed it when a healthcare provider on a routine checkup should have noticed things like that. And I've seen that his whole life. On my last sabbatical, I had a whole series of studies planned to focus on this. Then my mom fell and broke her hip, and I spent that entire sabbatical in Kansas City with Mom taking care of her, which was a wonderful experience. Imagine, your parent, my mom was 84, 85 at that point, to get that time with her she's probably approaching end of life sometime, don't you I think it was wonderful. And so maybe some other time I'll do those studies, because I had a nice plan for research. Age issues, of course, have always been something that we've been aware of in health communication, primarily because of scholars like John Nussbaum and others who have brought our attention to those topics. In terms of health organizations, we do see some submissions and some work on organizational culture and culture dependent on the type of healthcare provider. Historical patterns of acceptance of female physicians, minorities in medicine, various ways of managing conflict, holistic care, not enough in any of these. A little bit here and a little bit there. We really need to broaden that perspective. Mentioned already social support. So research focuses on the various social sources of support: action, nurturing, information, coping strategies, lay caregivers, end-of-life issues, those palliative care issues, so important. We've got several. You were the one who was interested in palliative care, right? Good. I wanted to make sure I had that right. Several communication people doing very good work in palliative care and the communication issues involved at the end of life. As a matter of fact, my presentation on Thursday, what I want to talk about are death and dying.
Unfortunately, I couldn't attend.
Darn. I'll send you the PowerPoint.
Thank you.
Because it's so important. It's something that affects every one of us. Over as supporting, and then virtual support. So, number of issues. Cultural concerns. I suspect that all of you in a very cosmopolitan, international environment are more aware of many of these issues than would be the typical scholar. So, the nature of health and illness, how they are conceptualized, health as organic, health as harmony. Western medicine has very limited perspectives on this and looks only at biomedical issues. social implications of disease, such as curse and stigma. Stigma was one of the topics with which I originally began my work because of disability issues, which tend to be stigmatizing, and I've been thrilled to see a real resurgence in writing and theory development and research on stigmatization. There are various cultural conceptions then of mechanics and machines as Western medicine typically looks at health, spiritualists and believers, providers and consumers, typo there, my apologies, and partners in healthcare. Then, all right. I said that there's been a lot of work on health information in the media. We see a lot of this focusing on advertising, and a lot more of this coming from the US and New Zealand than from other contexts, because those are the only two countries that allow direct-to-consumer advertisement of pharmaceuticals. So really interesting issues there. Issues that have led to policy changes that, for instance, have mandated Congress in the US to make laws saying that the contraindications, the side effects, must be spoken at a rate low enough so that people can actually understand that, etc. So it's led to some policy changes. It's been quite surprising with direct-to-consumer advertising how non-alarmed many viewers are by those long lists of potential side effects there. And again, you don't have them here in Singapore, but I'm sure you've seen them on television somewhere. And they can, cause hair loss and high blood pressure and eventually death. And people are not dismayed by that in the way that you would think, certainly in the way that pharmaceutical companies thought people would react as they were first putting these ads together. So, see work on advertising of health products, particularly direct-to-consumer advertising, nutrition, alcohol, body image issues, so kind of a lot going on there. News coverage of health information. How accurate it is, how fair it is. It probably doesn't surprise most people in this room to know that there's a lot of inaccuracies and unfairness there. Sensationalism, of course, we have known a lot about various communication technologies and then the advantages of news coverage. It's so much health information comes to us online. There, I don't know about you, but for me it's impossible to avoid pop-ups of presenting health information, or frequently alleged health information. And you know how it is. I suspect it's the same way here, but let me know. You search for something once, and then for months afterwards, do you get pop-ups on things related to that? My doggy was not doing very well. He died just last week. I had gotten him from rescue almost 10 years ago, and they thought at that time that he was 7 or 8 years old. Well, that's a really long life for a dog. And I had seen his deterioration. He couldn't really see, he couldn't really hear, his back legs didn't work very well. So I got on a line one night looking at doggy wheelchairs, essentially. They kind of have a strap around the doggy's waist, and they have little wheels. And I thought that probably would have helped him. by the next morning, I had 5 pop-ups about doggy wheelchairs. It took just hours. That was all. He passed away before I even made a decision about that. Very sad. Have you had a pet die? Very sad. It was my first time. But it was a fascinating example of how quickly the technology caught up with me. Entertainment, health information in entertainment media. So various portrayals of things like mental illness, dementia, disabilities, sex and violence, and the health implications of those. Healthcare situations, medical miracles are much more common in the media than they are in real life. Entertainment and commercialism and various entertainment, education programming, and edutainment. Now, there's a fair amount of that's done in India and various African countries, so I suspect that many of you know a lot more about that than I do. A lot on health literacy issues, both in terms of print and oral literacy, complexity and difficulty of the messages, media literacy in general, which is a part of what feeds into health literacy, numeracy, being able to understand what numbers mean. Something that some health literacy scholars don't tend to include in their research, but something that we know is very important. Computer literacy, of course. My mom, after all these years, still cannot cut and paste something on her computer. Of course, my ex-husband can't create a Word document. So I guess there's a lot of computer literacy issues. And then, of course, the impact of education and socioeconomic status on those. All of these leading into health disparities work, which is so tied in with the work that many of you here are doing. All right, for the 100th issue of the journal, a scholar from Purdue, Jung-Nam Kim, and some of his graduate students did a content analysis of everything that had been published in the journal during those first 100 years. They didn't actually set out with the goal of looking at the first 100 years. They looked at everything that had actually come out in print up until about that time, which had been past the 75th issue, but not up to the 100th issue. So I received this submission. I said, ooh, what an interesting idea. I said, this might be something good to include in the 100th issue of the journal. I better figure out when that's coming out. So I counted the issues and said, that's coming out pretty soon. I better get back in touch with them. So I then gave them access to everything that was still online that had been accepted and would come out through the 100th issue. So they were able to cover everything, a content analysis of everything that had been printed in the first 100 issues of the journal. A rather extensive job, especially because they looked at a whole bunch of variables there. So they looked at topic patterns over time. They found that medical communication was highest overall, but that peaked in about 01 through 06 and then declined from 07 to 2010. AIDS, HIV, safer sex issues were second highest, but peaking in 95 through 2000. You know, once we had the heart cocktails, there wasn't as much research on that. That was then followed by cancer. They excluded breast cancer because there was so much on that they made that a separate category. So cancer coverage peaked in 01 through 06, and coverage on smoking continuously increased. We're still seeing work on that, but with a slightly different twist. work on vaping, and e-cigarettes. Some scholars at University of Pennsylvania have been doing some fascinating work on that. We've kind of fast-tracked that to get it published online more quickly so that it can impact policy making. One of the really exciting things about our area of research is the real-world impact that it has, right? The impact on people's lives and the quality of their lives and how long they live and policies that impact all of these. So it's very exciting. The next biggest topic was health in general, followed by alcohol, highest 1 through 6. Breast cancer, which coverage has continuously increased. Drugs, and these were highest in the first period. I don't think that should be 29. I'm not quite sure what it could be because they looked at 5-year groups, so I would guess 92, but that's not a 5-year grouping. So my apologies for that. And then medication, highest in the first and last period. So they were interested in looking at how these trends changed over time. Then heart disease, which is highest in the last period, followed by organ donation, social support, and end-of-life issues. They also looked at the focus of the research, the research foci, in terms of things like audience, interaction, message, etc. So looking at the audience as the focus of the research was highest, followed by looking at the actual interaction, then at messages there. So a lot of the media content analyses would fall into here. Sender and channel follow, then narratives and evaluation. Narratives have been an exciting area of research that have emerged over time. Criticism, less frequent but increasing over the years. They also looked at the theoretical frameworks that were used. Note a theory, not having any theory, was highest, but that was primarily from non-communication, non-public health as scholars. Comm scholars and public health scholars are much more likely to ground their work theoretically. Then narrative theory, theory of planned behavior, various social norms, perspectives, primarily theory of reasoned action, and framing. A lot of work on message framing, making some important contributions. Then the extended parallel process model, work on compliance gaining and social cognitive theory, followed by self-efficacy and the elaboration likelihood model. Then grounded theory coming from a more qualitative perspective, health belief model, and problematic integration theory is developed primarily by Austin Babra. Did you overlap at Purdue with Austin? Now at Ohio University. So many people come through Purdue one time or another, don't they? So they also found some other trends that had occurred over the years. Something good, increasing interdisciplinary collaboration, especially between comm and medical/public health scholars, increasing reliance on theory. Funding patterns changed some over the years, increasingly from government and public organizations and private grants, decreasingly from university-funded research. And the funded research in general is much less likely to be theoretically framed. I see some of you nodding your head. You've come across that before. Increasing use of qualitative research and interest in health communication in Asia. Many of the leading health communication scholars in the world are in Asia. And now, we've seen some growth in Europe, some Europeans scholars as well. We've got the University of Lugano in Switzerland with the first doctoral program in health communication, the first doctoral program focusing specifically on health communication. Farther north in Denmark, et cetera, some parts of England, we've got a lot of really good work going on as well. But Asia is leading the pack in terms of the development of new work. For that same issue, I had a former student of mine and a colleague of mine do an analysis of the reasons for rejection of articles. I've got a couple of scholars now from University of Texas who are building on that in even more detail. So look for that in the future. Aaron Donovan and Mike Macker are working on that. But anyway, this piece for the 100th issue looked at why are articles rejected. So I thought this was an interesting one. Writing issues were concerns, lack of full information or lack of the information that would be required for replicability. Sometimes pieces were just not understandable. Sometimes the logic of decision making was not clearly articulated in the writing, and various errors, grammatical errors, APA errors. I tell you, APA errors have become more and more common since software came along that you would think would make it better, right? But the software doesn't get it right. You know, you think things like endnotes, etc., include issue numbers when APA does not include issue numbers, etc. So it's one of the two banes of my existence, I think, right now. APA errors. Before I send anything to press now, I make sure I go through the references, and I can edit APA in my sleep. It's sad, isn't it? You know? You'd think I'd be dreaming about handsome men. No, I'm editing APA in my sleep. But so those have become more common. Those are not fatal flaws, of course. Those can be corrected. But reviewers react to those kinds of errors. And if you can't, if your piece is not in APA, for instance, if you can't get things right, then they wonder about the other problems that are likely to be part of your work. So all of those writing issues were a part of it. An inadequate literature review or lack of a theoretical framework, common reasons, various methodological, measurement, and statistical analysis problems. Basically, what they found was that there were many times when authors did not provide the rationale for why they were using this statistical procedure, etc. Additionally, they found discussion sections that did not make a new contribution. You know, the discussion section is supposed to be there for a reason, not just to summarize what you found, but to make a new contribution. A lack of focus on communicative processes. I try really hard not to send anything out for review if it doesn't focus on communicative processes. But I think that what they were looking at included the desk rejects, you know, that I don't even send out for review. So I'm hoping that most of those did not go into the review process. What I thought was interesting was that no study was ever rejected for just one reason. They all had multiple problems. If a study had just one problem, then a revise and resubmit decision would usually be rendered. And I tend to look at editing as more of a mentoring and nurturing process. Then do some reviewers. So if there's a reject decision and a revise and resubmit decision, I'll look carefully at the reject comments and say, are these fatal flaws or are these things that could be addressed in a revision? So for me, like in baseball, the tie goes to the runner. I don't know if that's a statement that you're familiar with. For me, the tie goes to the author. I'll be more likely to give the author a chance. And I've seen over the years how much young scholars come along when you give them a chance to receive that feedback, to revise the work, to learn from the process. And of course, I think back to, as a young scholar, how I learned from the feedback that I got and how valuable that was. So I try to give authors every chance I can. If both reviewers say reject, then I will usually reject it. But if just one says reject and one says revise and resubmit, I'll look carefully at the comments from the rejecting reviewer, because frequently they are not fatal flaws. And the whole notion of fatal flaws are really judgment calls anyway, aren't they? The reviewing process, unfortunately, is subjective. We would like it to be right on track and straightforward, but it's not. These are judgment calls. So, okay, a little bit of editorializing there, although as an editor, I guess I'm allowed to editorialize, right? We also published in that 100th issue a study of citation patterns over time. We frequently lament, our work is not cited by others. Turns out that's wrong. It is. It's cited rather frequently. So that was, I thought, a pretty exciting finding. So Tom Feely and a couple of other scholars did a bibliometric analysis that shows that health communication does indeed serve as a link between communication and various health-related journals, just as we had hoped all along. So I found that very exciting. They too found that we had higher impact ratings than most other communication journals, and increasingly so. Now, also in that 100th issue, published an interesting, I thought, little piece that I co-authored with someone from the National Library of Medicine. Martha Zorn is her name. She just recently retired. She actually had a master's degree in communication from the University of Dayton before I was ever there, and I've been there, as I said, I'm in my 31st year. So she had a background in communication, was working at the National Library of Medicine, and I just have found her a very valuable source for a number of things over the years. So she gave me some advice for all of us on titling articles so that they will be cited. You know, we usually come up with kind of esoteric titles that are not likely to turn up in searches that other scholars are doing. Well, that's not what we want, is it? We want our work to contribute to the greater body of research. We want our work to be read by others, to be cited by others, to be built on by others. So she did some work for me on how we can do that. First of all, she said, use terminology that others outside the field use. So for instance, e-health, rather than computer-mediated communication, CMC. Evidence-based rather than empirical. Now, those are differences that are, one might think of as small differences, but they made a difference in terms of the searches that she did. And terms that seem broad to us, like health communication or doctor-patient communication, are search terms that are used by others who do not have the expertise in health communication that people in this room do. You know, we rarely search using the word communication because everything we want is going to be about a communication. But when we want our work to be cited, we should include very broad terms like that because that's what other people, other scholars will be searching under. Avoid jargon and specialized academic terms. We always like those so much. Hermeneutic and rhetoric are not good choices, that she found. So she gave me a couple of examples of that title. Evaluation of gain and loss messages in determining binge drinking, a test of the mediating and moderating role of psychological reactants. Now, Mohan knows exactly what this means, but the average non-communication expert say, okay, maybe I can, I'll look at the word messages, binge drinking, I know. What the hell is the difference between, what the heck is the difference between mediating and moderating roles? There's an interesting difference, right? But a lot of people without much training in the social sciences aren't familiar with it. Even those of us with trainings frequently have to look that one up. Okay, mediating versus moderating, etc. Measuring patient and physician participation in exchanges on medications. Look at this one. Dialogue ratio, preponderance of initiative, and dialogic roles. That article had been published 3 years before Marcia did this search for me and had been cited only once since the time, probably by one of the authors, right? Because we do tend to cite our own work. By contrast, she gave me a good title, although it's not a simplistic title, but it's using terms that show up. A multiple discourse approach to health communication. So it's got that key health communication term in it. Translational research, very big, and ethical practice. That's a good title. I think that was one of Roxy Parrott's. Doesn't that sound like something that Roxy would write about? Now, for many of you, the frequency with which your work is cited will be useful data at tenure and promotion at times. So it's something to think about. I'm serving again, year number 7 on my college tenure and promotion committee. I really thought I was odd at this time. Then somebody who was on the committee, his wife was going up for promotion, so he had to recuse himself, and guess who got stuck on it once again, year number 7. But those kinds of committees like to see those data, the frequency with which your research has been cited. So it's a trend that began more in the physical sciences, has gone more into social sciences, public health, medicine, etc. Something for us to think about. Now, as I've looked at new directions in the journal over the years, I've seen some interesting things developing. All right, so then some new directions in that I've seen over the last few years. A lot of broadening examination of health problems, which I think is really important, including mental health issues. Those are so much more difficult to study than many of the physical health issues that we're prone to study. There are some scholars, like Eileen Berlin-Ray, who've been trying to advocate this for quite some time, and I'm getting submissions in this area now. It's very exciting. The problem is I don't have enough reviewers for the submissions that I'm getting. There's always a lag between getting submissions in a new area and being able to develop enough reviewers to cover them. More concern about the underserved, represented racial and ethnic groups. And of course, Mohan has contributed to much of that. A lot more on globalization, very exciting, increasing examination of issues that relate to dailies, disability-adjusted life years, something that more and more of us are going to experience as we get older. My mother is 85 now, and she uses a walker. She's broken one ankle twice and one ankle another time, wrist once, and then broke a hip a couple of years ago. And this past August, she broke the right wrist again. Well, you can't use a regular walker when you've got a broken wrist. So they had to put together this fancy one for her with a big pole coming up and a cradle on it. But now she's back to a regular walker. More and more of us experience those disability-adjusted life years as we live longer. More hearing loss. Fortunately, with most of our eye problems, there are a lot of things they can do, treatments of cataracts, etc. But in general, life is changing as we are getting older. And then, bless you, more discussion of community health issues and health policy. One of the things, though, that I found interesting, also this was also for the 100th issue, was the difficulty that many of the scholars with whom I work regularly had documenting the real-world impact of their research. So I put out a call before that 100th issue, and I said I'd like some little essays about the real-world impact of your work. And everything that I was getting, I'm sure you remember this, Mohan, as senior editor, many of the things that I was getting were things like, here's how my work could have impact. That's not what I was asking. I know it hasn't, but we talk about that at the end of every paper, the impact that it could have, etc. But we tend to stay in the academy a little too frequently. Bless you. One of the most interesting ones that I got was from an Australian, a scholar who's done a lot of work on media representations of suicides and the copycat tendencies that occur after particularly celebrity, but not exclusively celebrity suicides. So they had put together a training program for journalists on how to cover suicide in ways that is not likely to lead to copycats. Now, those were the kinds of pieces that I was looking for. Once I got word out to people, they say, "Oh, okay, I see what you mean." But particularly as health communication scholars, that's what we need to do. Get out on the policy level, get involved with community health issues, and have an impact. Also, a lot more about pregnancy issues. Now, I'm sure that it won't surprise this group of scholars to mention that this is the most significant health concern for most females in many parts of the world. You know, in the West, we don't think about that. I'm guessing in Singapore, the pregnancy is fairly safe. What do you think? Yes. But in a lot of parts of the world, that's not the case. And pregnancy issues are the biggest problem. And we spend very little time studying them or dealing with them. I read not too long ago, fascinating book called A Path Appears. Have you heard about that? By the same authors as Half a Sky. What are their names? I'm sorry? That's it. Nicholas Kristof and Sherry Woodan. So Half a Sky, a documentary was also made of that, documented oppression of women across the world. It was just really a life transforming book and documentary. Their newest one, called A Path Appears, talks about the things that all we regular people can do to help address health problems across the world, frequently in less developed countries, a lot in Africa, but in every country. I suspect that there are a lot of Asian countries with significant health disparities. What countries come to mind? Significant health disparities.
Just one year, Nepal.
Nepal, great example, yep. So there are things that we can do to take our expertise and go beyond publishing in journals. That's just a start for us. We need to get out in the world. And then, of course, the increasing channels of communication that are available for content analysis. I see a lot more content analyses of things on YouTube than I do in the mainstream media, for instance, because that's where people get so much of their information. More variety in the health issues covered. Got published one not too long ago called Getting Boozy in Books, looking at books read by adolescents and how alcohol issues were treated in there. That's a new direction for research. Cyber coping, cyberbullying, all kinds of cyber issues. A lot more emphasis on structural factors and social policies, how these impact health and health disparities, examination of how health is constituted amid broader structures of political, economic, social, and cultural organizing processes. And your department here is an exemplar of that. A more of a lifespan approach to health campaign evaluation, something we haven't done very much with health campaign. We're looking at how different messages are needed across the lifespan, and then the value of defining moments. I suspect that those of you who have had a chance to read the journal have seen that usually at the end of every issue we have one or two little personal pieces on defining moments in health communication. Mohan, have you published any of those?
Yes.
I thought you had. Do you remember what yours was on?
Yes, so mine was on the state's response to Maoist violence in India.
Wow.
And the health outcomes attached to that.
Excellent.
So, the beauty of that section was that it allowed me much more freedom to write poetry and,
Right, yep. So, not a traditional academic director, although there are some medical journals that also publish defining moments. So we've had pieces there about putting mom in the nursing home, end of life discussions, the infertility issues, pregnancy issues, etc. So these tend to be short pieces, things that I'd encourage you to think about. We all have these defining moments in our life. So these are little pieces to get us to think about additional things. All right, now, since many of you are young scholars, by my standards, you're all young scholars. I remember being at an ICA Health Comp division, a meeting, and Rajiv Ramal was running it. He was the president of that. And Rajiv, of course, is from India. Do you know what part of India he's from?
Nepal, right? Closer to Nepal.
Oh, okay, very good. Anyway, we've been talking earlier in this session, and I had mentioned something about young Turks versus old buffaloes in the field, and Rajiv was trying to refer to it later, and he said, as Terry says, old cows. Old cows. I've teased him about that one ever since, but it was a compliment, right? The cow is sacred in India, so I was not insulted that I was being called an old cow. Anyway, some issues then are related to how you think about your publication, and some of you are old hands at this, so my apologies. Then first, look at the journal in which you're publishing. as I mentioned, you don't want to send something in and have the reviewer say, perhaps you've never had an opportunity to look at our journal. So do that. And of course, that's easy to do in today's world compared to how it used to be when we actually had to find a hard copy of the journal. Then follow the instructions and the format carefully. When someone sends in a piece to me that's in AMA rather than APA, I know that they have not prepared the piece for this journal. It's not that difficult to switch the format, although as an author I do find it a pain in the neck, but actually it doesn't require that much time. But having something in the proper format communicates the seriousness from you as the author. Choose, of course, the most appropriate journal. Go to their submission website. Do prepare for blind review. I still receive pieces every now and then that are not actually prepared for an anonymous review. You know, reviewers not supposed to know who the author is, and the authors are not supposed to know who the reviewers are. So for most of us, those are kind of issues. Then some guidelines also. First, most obviously, do good research. You already know that. Choose doable topics until you're tenured. I think Mohan is the best example I have ever seen of someone who did this. When he first started submitting to me, he was a graduate student. Then, all through his years at Purdue, he was doing highly quantitative work, a fair amount with the hints data. There, he was getting article after article after article publishing. As soon as he got tenured, the real Mohan. And he was able to study what he really always wanted to study. But the kind of work you do now takes a lot of time. Yeah. Can you talk to us a little bit about kind of your thought processes?
Absolutely. So, in a sense, up until the point building up to tenure, the kind of community-grounded work I really wanted to do that takes about 3, 4, 5 years till you get your first publication out.
Exactly.
So in that sense, the secondary data was handy and really helpful. And just as you said, the role of mentors, I had great mentors who really said that you should really focus on strategy and think about things that you need to get out, and then also gradually think about things that are closer to your heart.
Good. Excellent. Now, you don't think that I'm using Mohan as an example just here, because I use him as an example everywhere I go and talk about that. He's such a well-established scholar, and again, just a perfect example of the approach that you should take until you get tenured. Do things that will be easy, and being a little OCD about your work is probably helpful, right? I would send Mohan a decision, and 2 days later he would have the revision back to me. So that's helpful too. It's quite shocking, isn't it? But it really is true. So then choose doable topics until you're tenured, and of course follow all the guidelines you were taught in graduate school. That's a frustrated young author. Does that look familiar to any of you? Yeah, it looks familiar to me too. I'd encourage you to think about publication outlets before you conduct the study. Don't do a study and then say, I have no idea where this would be publishable. Think about that ahead of time and talk to your mentors, etc. You want to establish liaisons with others working in the area, both at conferences and through other channels of communication. I will frequently at conferences when I'm able to get away and go, which is not nearly as frequently as it used to be, have young scholars talk to me about ideas. Do you think this is something that would be interesting? Or if they can't catch me at a conference, to email me. Now, the most common kind of email that I receive along those lines is one where the piece has already been conducted, and they're saying, do you think this would be appropriate for health communication? And I get several of those a week. And I'd encourage you to send those kinds of emails out to editors. Most editors are very responsive to them. That's part of how we mentor the field, by giving feedback about that. And if someone has done something that's not really focused on communicative processes in a conceptually sophisticated way, I'll tell them, no, probably want to try maybe a health psych. A journal that would have somewhat different standards about conceptualizations of communication. If it's not theoretically based, I will tell them that, and that it would probably be better to try elsewhere. There are some pieces that are really more geared towards practitioners than researchers. Well, they should be published in places where practitioners will read them, where they will be able to have an impact there. And makes editors very happy if you don't make the piece any longer than it has to be. It's hard for us. Our research, there are babies, right? There are children, and we want to spell out every thing. But if a piece is 35 pages, and I know very few journals that will publish 35-page articles. Our page limit is 25. But even then, I ask every single author to cut the piece once it's been accepted. There again, based on my experience, I know anything can be cut. So I ask every author. It's standard, isn't it, Mohan, in our letter of acceptance with revisions. Even if no revisions are required, the author always gets a letter of acceptance with revisions once we've gotten to that stage. And we've usually gone through several iterations of review before we get to that, although every now and then, maybe twice in all these years, actually, I guess I should say, something was accepted right off the bat. But most of the time, it's several iterations of revision and resubmittal before it gets to acceptance. But then even if there are no revisions requested, they get the acceptance with revisions letter, because that's the one that gives them instructions about submitting the copyright form. If we go right to the acceptance letter, then there's no instructions about the copyright form, and that letter always says, try to cut it a couple of pages. If every author can cut a couple of pages, then we can fit an extra article in per journal. Which just ends up making more work for me, so maybe I should change that now that I think about it. But anyway, don't make the piece any longer than it must be, and do be aware that there's a good chance you'll be asked to cut it. As I've already said, do feel free to communicate with the editors. Look at editorial boards. See who might be likely to review your work. If you see that someone whose work you're criticizing is on an editorial board, you might want to avoid, no, I'm going the wrong way. You might want to avoid that. That's an offended reviewer. I have no idea what it really is, but it looks like an offended reviewer to me. So don't offend potential reviewers. I don't find that happening a lot. Most of us in our writing are fairly civil. And if we are criticizing someone else's work, we try to put it in a diplomatic way. So I haven't had a lot of problems with that. Historically, in our field, there have been some battles, not in HealthCom per se, but in the broader field of communication. There have been some battles with people offending each other, but that's not usually much of a problem. So,
should I keep the questions toward the end?
Oh no, questions are fine now, and I'll keep this picture up here so we can stare.
So I want to know how you feel feel about the suggestions for the reviewers as the authors? How do you feel about that mechanism? Because sometimes
Yes.
I don't know how other people feel. Sometimes I feel that I prefer not to recommend any reviews to indicate that I trust the blind
Yes.
review process. But I also see some people try to abuse that system.
You're right.
Yeah. So how you?
I generally ignore any suggestions that are made for reviewers, but I do know some editors who welcome that. I know a lot more who don't welcome that. I was talking recently to a friend who's one of the editors of Journal of Personality and Social Psychology. It's a very competitive journal. He says he would never use a reviewer that an author had recommended. The only time I do it, and I've probably only done it 2 or 3 times over the years, is if I am completely stuck. And I might send a note back to the author saying, I cannot find anyone to review your piece. Can you give me some suggestions? More commonly, though, I'll send somebody else. So if it's a critical cultural piece, and Mohan's already reviewing something else for me, which he always is, I'll send it to him and say, do you have any ideas about who might be good for this? And he'll give me some suggestions. He'll say, oh, I should have thought of them. Yeah, but I don't usually respond positively to the
I also feel more
suggestions.
comfortable with this kind of decision because for some journals that when I submit the papers, they require you to provide true names of the potential reviewers, and then I suddenly feel like I don't want to name my friends.
Right.
But then,
Exactly.
But then what's the assumptions behind these the recommendation process? I'm just
I don't know what the assumptions are underlying that, but I too have seen it, and I've always wondered why. It seems to me that the editor wants to take the easy way out, I was asked recently to provide some recommendations for a piece that I was writing for, it's some international online encyclopedia of communication. Roxy Parrott's doing the portion on health and risk communication. And I had written a piece for her on adherence. And she did ask for some suggestions, and I was able to give her some with whom she was not familiar, but that's not the same as a typical peer review,
And then I started receiving emails from my friends saying that, oh, by the way, I nominate you to be my reviewers, and these are my papers, the title of my papers. So I will be very happy to, revise the paper based on whatever comments you give me. I was like, okay, friends, you
that puts you in a very awkward situation.
Right, then I didn't say anything, so I just hope that, hopefully that the editor will never ever, contact me. If yes, I will say I'm available, because it's not anonymous. I feel uncomfortable.
Yes, you're right. I do too. Yes. Yes. And I think as an author, except for this one time with this online encyclopedia, I never have suggested reviewers. But again, there are a few journals that do like that. So if they ask you for recommendations, I think it's best not to recommend your friends, as you say, but to recommend other people who are experts. So this online piece that I did, none of the people I recommended were my friends, but they were people who I knew who'd done work on adherence. So please feel free. Any questions that you have at any time. So are you done looking at his face? Yeah. All right. Revising. Then always be ready to do so repeatedly. I once made Michael Burgoon go through 7 revisions of a piece. I finally had to write to him, Michael, you cannot talk your way into print. Not a great line, it wasn't mine. Really, my ex-husband had been told that line by a reviewer of the Quarterly Journal of Speech a number of years in the past. But he thought that instead of revising the piece, he could just explain why it was okay. Now, sometimes that's acceptable, right? There are times when providing a rationale for why we made the decisions leads the reviewer to say, oh, okay, I'm cool with that, and that's acceptable. And I remember when I had to teach you this, Mohan, the response to reviewers is every bit as important as the revisions themselves. Be detailed. Remember that reviewers are now invested in your work. And don't offend them now either. I once had to send a piece back to Tom Feely because the response to the authors, to the reviewers that he had written was so defensive. I said, no, Tom, I'm not going to send this back to the reviewers. When Mohan was a very young scholar, I once had to say, no, you need a more detailed itemization of the changes that you've made. And every single time since then, you've done that. So don't be defensive then. Cry and move on. That too looks familiar, doesn't it? Yep, crying and then moving on. As you think about publication, do again think about the importance of the theoretical base in terms of increasing generalizability of findings, as we've talked about, the value of the work, and keep in mind that methodological statistical sophistication is good, but it's not as important as using the appropriate methods and statistics. I have one colleague whose work was rejected and he complained because he used these fancy statistics. Well, that's not going to make good research, just using fancy statistics. I don't think he ever did get that piece published. So, some common mistakes. Lack of anonymity in some way, not including the response to reviewers in the appropriate slot. There is a tendency among some young scholars to put the response to reviewers in the cover letter. Reviewers can't read the cover letter, so they don't get that. There's a separate download slot, and I don't know if slot's the right word or what, I don't know what to call them, but a separate place where you download the response to reviewers. So make sure that you do that. Mistake, of course, would be resubmitting when you haven't thoroughly addressed the reviewer's concerns. I have found numerous times that authors will resubmit a piece and then they don't approve the PDF in the submission process. After you submit it, there will be a point, you have to wait a little while till the PDF is approved, and then it won't, until the PDF is made, and the system will not let you approve it without really looking at it. I know because I tried. You have to really open it up and look at it and then approve the PDF. I've had scholars who were waiting for months for a decision from me when the piece had never come back to me because they hadn't approved the PDF in the submission process. So be careful of little details about that. And don't acknowledge the limitations of your research and then argue why they aren't really limitations. Every single study that's ever been done has limitations, right? No matter how good our research is, we all have limitations. So don't say these are limitations, but they're not really that bad. Just let it go. Makes you look bad to do that. And know that you can't make any substantive changes once the piece is moved to final acceptance. When you get the proofs, there's a tendency to want to clean up the language a little bit. No, you can't do that. You can only correct mistakes that have been made. In some of the early psychological reactance research, there was a change over a couple of years in the terminology that was used. Brian Quick, one of my senior editors now, had a piece accepted, and at that time our backlog was even worse than it is now. We're really trying to cut that backlog down. Not only are we going to 12 issues effective this January, but each issue is going to be even longer for 1 year to try to get rid of that backlog. Anyway, so we had a bit more of a backlog then. So in the time since Brian had first written this piece, a common terminology, I don't remember what it was, but it was something related to reactants, had changed. People said, we shouldn't say this, we should say this. So he went through and made 50 changes in the piece at the proof stage to catch up with what was now acceptable. No, you can't do that. He's not the only one who's done that. I've had one or two scholars over the year. But keep in mind, you can't make any substantive changes once you've gotten to the final acceptance stage. Keep in mind also the importance of communicating with your chair, your director, etc., and your mentors. I hope you all have some to determine expectations. So Mohan talked about this. My first chair used to say to me, "So, how many articles did you write last night?" The reason that he did that was to nag me, and he was very funny. He and he was a good chair, but he wanted me to keep him posted on what I was working on. My then husband had started at this University of Delaware 2 years before I did, and he was working on things, but he wasn't telling anyone that he was working on things. So, if you don't tell anybody, they assumed he was not working on things. When I then applied for a position, they were hesitant to hire me because they didn't want to hire me and then have to terminate him a little while later. So we had a meeting a Sunday afternoon in my chair's office, basically that involved the chair asking my husband, "So what are you working on? Are you keeping busy? Are you likely to get tenure?" If he being my ex-husband, had just kept people posted about what he was working on, that wouldn't have been an issue. So let people know, ask for their feedback, etc. Let them know what you're working on, and you will find, of course, that feedback generally very helpful. I remember as a master's student, people knowing about my interest in disability, stigmatization issues, and I come in to the office, and some professor would have put an article on my desk that he had come across, etc., and was very helpful at that time. Now we'd email the citation to someone, but this was 1975, I think, so we didn't have email then. A few related thoughts for you again as young scholars: being careful about citation and claiming terms, etc. Even in terms of plagiarizing your own work, it affects your reputation. I had a reviewer contact me last week or the week before, and she said, "Terry, could we talk on the phone?" Which always means that it's something somebody doesn't want to put in writing, right? And she had just reviewed a piece for me, and she said, I am pretty sure that this author is self-plagiarizing. That this author had used this exact same language in a previous piece that she wrote several years before. So this reviewer was bothered by that. She went through, she took the two pieces, she highlighted for me in yellow the overlap. Now, turned out that was a piece that was not going to get published anyway. The reviewers had I had 3 reviewers for that one, and they'd all voted for rejection. But I was able to indicate to the author, in addition to these problems, self-plagiarism is not acceptable. Again, even when it's your own work, it's still plagiarism. Someone else now owns that copyright, and so you can't do that. I'd encourage you, again, as young scholars, about the need for active involvement in your professional organization. That's how people will get to know you even more than through your scholarship, although you want both, obviously. And then the issue with which we started, disciplinary, interdisciplinary, multidisciplinary, transdisciplinary, translational work that we can apply to real world settings, getting your work in the public eye. You have a responsibility for that. We all do. As we do a work, we got to get it out there. I mentioned the suicide a piece before. Most universities, and I don't know how NUS is, you may have some thoughts about this, but most universities have PR offices that will publicize your research. I've had my research discussed in Glamour magazine, not your typical, twice actually, in Glamour magazine, on the front page of the Wall Street Journal, twice discussed by Jay Leno in his opening monologue on The Tonight Show, when he was he was making fun of it, of course, University of Dayton researchers have found that, and then went ahead to make fun of it. But that kind of dissemination is what we want to go on to, not Jay Leno so much, but some of these others, so that real people learn about our research, and it has an impact. So I feel that we have a responsibility for that as scholars. Now, I know Mohan talked to you recently about reviewing, so I will probably be redundant with some of the things that he said, because he wrote a wonderful article for me that came out of a dinner discussion that he and I had at a conference when we were talking about reviewing, and he was expressing some thoughts, and I said, write that up, and he did, and I suspect he referred to some of those ideas, although I'm sure you've had others come up since then. But for Mohan and I agree in a way, not all of my reviewers do, that reviewing is a nurturing and mentoring process. I've used those words already, but it's a chance to shape our field, to shape the directions of research, to provide feedback to young scholars, and to shape them. We're not here to sort the wheat from the chaff. Is that an expression that you're familiar? We're here to mentor scholarship and to try to make it as good as possible. I do find a double standard with authors and reviewers. I'm thinking of one particular scholar who's at Louisiana State. He's incredibly picky as a reviewer, but if anybody criticizes his research as an author, he's all up in arms. We can't have those kinds of double standard. And if you won't review for a journal, don't expect to publish. I'm not addressing anybody in this room, but there are a few people around the world who turn down virtually every review. You know some of the people I'm talking about, Mohan. They're too busy. We're all busy. If we want to have an impact on our field, we have to be willing to review, not just do our own scholarship. There are some scholars who I think are very selfish, and are concerned only about their own work rather than about making a broader impact. I encourage reviewers not to reject articles for reasons that are not really fatal flaws, to be constructive in their comments, and to please try to respond within the requested time frame. I give reviewers less time than do many journals, because I know they're still going to be late. I ask them to respond to the invitation within 4 days. For some reason, review invitations are more likely to be spammed at many universities than are the uninvited invitations that come when they didn't respond. So I'll get an email from them saying, well, what are you uninviting me for? I didn't get the invitation. I said, check your spam settings and It's almost always there. But because the invitation has a link in it, it's more likely to be sent. At least that's what I'm told. I really know nothing about how that works. So I give reviewers 4 days to accept or decline the initial invitation. I do miss the old days when I didn't ask them if they were willing to review. I just sent it to them. When we first started the journal, we didn't even have BitNet, which you won't have ever heard of, but it was pre-internet. That we didn't have email, so everything went out hard, a copy, and I didn't ask people, will you review this? I just sent it to them and made them review it. And I thought that worked pretty well, but I think I was exception there. After they accept the invitation, then they're asked to respond within 21 days. Frequently, they will email me back saying, can't do it in 21 days, you give me twice that amount of time, I can do it, and I say, go for it. Just ignore the reminders that you get from Ed Manager telling that you're late, and most of them are pretty good at ignoring those, it seems. Joe Capella feels so guilty if he's late with something that he will not accept an invitation. I have to beg him. I say, Joe, please. Well, just ignore the reminders. I really need your input on that. Our submissions are so high. Did I already complain about this to you? So 120 at a time is what I'm usually dealing with on any particular day. I just don't have that many reviewers, and again, everybody thinks they're busier than everybody else. So when I ask you to review, please say yes. And then again, please try to respond within the requested time frame. I already referred to this notion's need for unselfishness in your career. Our careers are not just individual things. Now, I'm speaking to a lot of people from a collectivistic culture, so I'm guessing you already know that. In the U.S., people are much more individualistic, and they look at their work as their work, not part of the broader community. We're all working together to generate knowledge about the health communication process. And I think if we look at it in that way, it makes for better scholarship all around. So part of scholarship is reviewing, mentoring others. Notice I didn't put any names in here. I thought of several. After some scholars are very selfish in their careers, but I didn't put any names in there then. And respond to review invitations. Did I mention that before? Okay, I have been thinking a lot about the influence of publication outlets on the development of an area of study, and health communication is certainly a classic example of that. It moves established scholars into a new area, as I've mentioned, persuasion, mass comm scholars moving into health communication concerns special issues as publication options. Andy King from Texas Tech University is working on one for me right now. I think it's focusing mostly on graphic novels as tools of health communication. Now, isn't that an interesting topic? Opens up a whole new area there. So keep your eyes open for that. Also, important is keeping lines of communication open so that you hear about edited books for which your work might be appropriate. And then looking outside the discipline as well in the variety of different medical journals. Thinking a little bit about the paradigmatic state of the field. We've got Judy on board. Are there any paradigms that need shifting? This might be you. A few years, what's that, boy? A paradigm shift? And then finally, disseminate your research, publicize your findings, impact policy, and get involved at the local level.